Hi, my name is Garrick Stewart, and I look forward to giving you a board review in cardiology. Thank you for participating in this course. I have no relevant conflicts of interest or disclosures, so let's jump right in. Question number 1. A 78-year-old man with bioprosthetic mitral valve replacement and a 10-year history of diabetes mellitus presents with new onset atrial fibrillation with a heart rate of 82 beats per minute and blood pressure of 156/96. Echo reveals ejection fraction 56%. Which of the following is a true statement? A, restoration of sinus rhythm reduces risk of stroke compared with rate control and anticoagulation. B, warfarin has a lower risk of intracranial bleeding than apixaban. C, apixaban should be started to reduce risk of stroke. D, the combination of aspirin and clopidogrel is equivalent to warfarin. Or E, the patient can be cardioverted now and complete 4 weeks of dabigatran. So this is a case of somebody with newly appreciated atrial fibrillation. And I think the true statement is that apixaban should be started to reduce the risk of stroke. We know that the risk of stroke is driven by the CHADS-VASc risk score and not whether you're in sinus rhythm or atrial fibrillation at that given time. We also know that apixaban has a lower risk of intracranial bleeding than warfarin. Let's go into this a bit. The CHADS-VASc risk calculator is now the predominant way of determining if somebody's at risk of stroke with atrial fibrillation or atrial flutter. This patient is older than 75, so that's 2 points, has high blood pressure, that's 1 point, as well as diabetes. So they have a CHADS-VASc risk of 4, and anticoagulation is indicated if the score is greater than or equal to 2. Really, it should be considered in men if the score is more than 1, and women more than 2. Sex alone is not enough to justify anticoagulation, even though female sex gives you 1 point. Now, these non-vitamin K oral anticoagulants or novel oral anticoagulants are now in widespread use. The most common, rivaroxaban, apixaban, and edoxaban, are 10A inhibitors. They have the XA or 10A in the name. The dabigatran is an oral thrombin inhibitor. And these are used for non-valvular atrial fibrillation. Now, what does that mean? It means atrial fibrillation without moderate or severe mitral stenosis or without mechanical valves. This patient had a bioprosthetic valve. Therefore, that's considered non-valvular atrial fibrillation. It's important to make the distinction because these newer agents should not be used in a setting of a mechanical valve or moderate to severe mitral stenosis. Let's move on to the next question. A 42-year-old man presents with several days of sharp substernal chest pain that's relieved by sitting forward. He had a similar presentation 2 years ago. Physical exam reveals flat neck veins, irregular rhythm, a friction red, and clear lung fields. A 12-lead ECG is obtained. Here it is. Randomized placebo-controlled trials have shown which of the following agents to be beneficial in the treatment of this condition: infliximab, colchicine, corticosteroids, cyclophosphamide, or metoprolol. So the answer here is colchicine, and the key to this question is recognizing that this ECG, presented here again, is that of acute pericarditis. There are diffuse, saddle-like ST segment elevations across multiple different distributions without any reciprocal changes. That characteristic chest discomfort relieved by sitting forward is also classic for pericarditis. Pericarditis is typically treated with NSAIDs, non-steroidal anti-inflammatories, plus colchicine. This is one representative randomized placebo-controlled trial showing that colchicine improves survival free of incessant or recurrent pericarditis. So it's an important drug in the armamentarium. Some of the bigger gun anti-inflammatory agents need not be used, and we tend to avoid corticosteroids at all costs because of the challenge of weaning patients off such therapy. Question number 3. A 65-year-old man is admitted with heart failure. He's noted to have orthopnea and progressive fatigue over the last 6 months. He's been previously healthy, and in fact last year had a coronary CT scan that was without any calcification. On exam, he appears chronically ill with a low blood pressure, narrow pulse pressure 90/75, and a heart rate of 100. He has numerous ecchymoses scattered over his extremities. Jugular venous pressures are elevated, carotid upstroke volumes are low. Lung bases are dull. There's a soft holosystolic murmur, a summation gallop with a prominent P2, ascites, hepatomegaly, lower extremity edema with cool extremities. ECG shows low QRS voltages, and yet echocardiography shows an EF of 50 with thick septal and posterior walls at 2 centimeters. There's a markedly elevated NT-proBNP level. Which of the following is the most likely cause of his heart failure? Coronary artery disease, cardiac amyloid, thiamine deficiency, constrictive pericarditis, or aortic stenosis? Well, given the clinical presentation in the STEM, I think the most likely cause is cardiac amyloid. Coronary disease, even though he's a 65-year-old man, there's no calcification on the CT from a year ago. Thiamine deficiency, exceedingly rare in nourished populations of high output heart failure, which this patient does not demonstrate. There's no mention of prior radiation or TB or surgery that would suggest constrictive pericarditis. And he had an echo where aortic stenosis was not mentioned. The diffuse biventricular heart failure symptoms and that discordance between the low ECG voltages and the thick heart wall are pathognomonic for the infiltration of protein within the heart of cardiac amyloid. This is a representative echocardiogram on the left, a normal heart on the top left with normal wall thickness, and on the right, a hyperechoic speckled heart with amyloid infiltration. On the bottom are representative H&Es from cardiac pathologic examination, where you have normal myocyte bundles on the bottom left and a normal heart, and those same bundles infiltrated with this bluish purple protein that causes disruption, fibrosis, and thickening of the heart. A very common condition, particularly in the aging population due to transthyretin amyloid, also can be seen in plasma cell dyscrasias, so-called AL amyloid. Next question. A 64-year-old woman with chronic systolic heart failure, EF25, New York Heart Class 2 and 3 prior hospitalizations, presents for a routine visit. She's euvolemic, has a heart rate of 60, blood pressure 110/62. She's on good doses of medicines, carvedilol 25 BID, enalapril 5 BID, eplerenone 25, creatinine's 1.2 with a normal potassium. What's the most appropriate step to reduce cardiovascular death and heart failure hospitalization? Do you transition from eplerenone to spironolactone? Do you want to start digoxin every other day? Initiate ivabradine 5 milligrams twice a day. Stop enalapril and start sacubitril valsartan 24/26 BID no earlier than 36 hours after stopping the ACE inhibitor. Or do you want to add losartan to the regimen? Well, I think the best answer to reduce death and hospitalization is to stop the enalapril and replace it with sacubitril valsartan after a washout period of 36 hours. Now, if you look at the other answers, there's no differential benefit between eplerenone and spironolactone. Digoxin helps with symptoms but doesn't reduce mortality. Ivabradine is great for patients in sinus rhythm with elevated heart rates, but her heart rate is low. And then the addition of losartan to the regimen may cause difficulties with renal function and potassium retention. We know from the Paradigm HF trial, still the largest randomized trial of low EF heart failure, that replacement with the angiotensin receptor neprilysin inhibitor sacubitril valsartan, or Entresto, is superior to the gold standard, the previous gold standard ACE inhibitor enalapril. There was a 15% relative risk reduction at a year, and a primary endpoint of over 3 years of follow-up of nearly 5% absolute risk reduction of cardiovascular death or heart failure hospitalization, with a 20% relative risk reduction in a number needed to treat of just 21. This very important study led to guideline changes in 2016 here, where it says that for initiation of treatment of low EF heart failure, you can start an ACE, an ARB, or an angiotensin receptor neprilysin inhibitor. And importantly, it's a class 1 recommendation in patients with chronic symptomatic New York Heart class 2 or 3 heart failure already tolerating an ACE inhibitor, that replacement by an ARNI like sacubitril valsartan is recommended to further reduce morbidity and mortality. The key thing here is anybody who has a history of angioedema should not get this drug, and anybody on an ACE inhibitor should have an interruption of at least 36 hours to prevent drug interaction. Next question. Question number 5. A previously healthy 38-year-old woman presents to the emergency room with lightheadedness, palpitations, and generalized fatigue. She just returned from a wonderful 2-week vacation to Martha's Vineyard and noticed a rash on her left thigh. An ECG is performed. You can see this ECG, the narrow QRS complexes marching through at about 40 beats a minute. And then here, the atrial activity, the P waves, somewhat faster at 70 beats per minute. And there is no apparent relationship between the P waves and the QRS complexes. So this is complete heart block. Each of the following statements regarding this patient's underlying condition is true, except this is a common cause of cardiomyopathy. B, steroids may improve symptoms. C, AV block often requires temporary cardiac pacing. D, pericarditis is common and responds to indomethacin. Or E, myocarditis may occur in 10% of patients. Each is true, except that this is not, in fact, a common cause of cardiomyopathy. What this patient has is complete heart block and a characteristic rash, sometimes called a bullseye rash or erythema migrans from Lyme infection, a borreliosis from a tick bite, exceedingly common in the Northeast. This patient just vacationed at Martha's Vineyard, as well as the upper Midwest. Pericarditis, heart block, extremely common, sometimes requires pacemakers, and indeed sometimes requires steroids to reduce myocardial edema. But in the end, Lyme disease is actually a relatively uncommon cause of cardiomyopathy or reduced cardiac contraction. Next question. A 55-year-old woman presents for a new patient visit to establish primary care. She reports a history of osteoarthritis to the knees, but takes no prescription medications. She has a normal exam except for a resting blood pressure of 158 over 98 in both arms after a period of repose. She comes back in a week later and has another blood pressure that's still 154 over 96. Fill in the blanks. A normal blood pressure is blank, and this patient has stage blank hypertension. Is it less than 140 over 90? Stage 1. Less than 130 over 80, stage 1, less than 130 over 80, stage 2, less than 120 over 80, stage 1, or less than 120 over 80, stage 2. And so the correct answer is a truly normal blood pressure is less than 120 over 80. And now with the latest guidelines, there are only 2 stages of hypertension, and this patient has stage 2 hypertension. The new AHA-ACC categories for blood pressure in adults: normal is a systolic less than 120 as well as a diastolic less than 80. Elevated is considered between 120 and 129, or on the systolic side of things, whereas hypertension, you need either a systolic blood pressure greater than 130 or a diastolic pressure greater than 80. If you're within that 130 to 139 or 80 to 89 is considered stage 1. But anything higher than that, anything more than 140 or more than 90 is considered stage 2. And you get categorized based on the higher of the systolic and diastolic curves. This revision of the blood pressure guidelines was largely based on the SPRINT trial. This was a trial of older adults with elevated blood pressure who were not diabetic but who were at risk for cardiovascular disease based on risk estimators. Over 9,000 patients were randomized to a strategy of either standard treatment targeting a blood pressure less than 140 or more stringent blood pressure control to less than 120. And with intensive treatment, there was about a 25% risk reduction in major adverse cardiovascular events, with a slight trade-off of a higher risk of emergency room presentation for dizziness and syncope. This altered the threshold for blood pressure treatment in the latest guidelines, as well as the goals of treatment. I think the key thing here to recognize is that once pharmacotherapy is initiated for elevated blood pressure, the target is essentially the same, which is less than 130 over 80. However, the treatment thresholds differ for different populations. The ones worth remembering are for those people who have no cardiovascular risk or extremely low risk. The threshold to start treatment is greater than 140 over 90. Similar for those where we're doing secondary prevention for stroke. But for every other population, a little bit of risk, chronic kidney disease, diabetes, heart failure, you begin pharmacotherapy for blood pressure if it's more than 130. Question number 7. A 33-year-old woman presents to the emergency room at 25 weeks gestation with progressive dyspnea that's now at rest and orthopnea and fatigue. She has no prior known medical problems, but her physical exam is notable for opening snap after S2 with a 1 out of 4 diastolic murmur heard best in the left lateral decubitus position. She's tachycardic at 108 and normotensive. She receives oxygen, intravenous furosemide, and diltiazem. Echocardiography demonstrates a mitral valve area of 0.5 centimeters squared, consistent with severe mitral stenosis. But she has normal left ventricular ejection fraction. Which is the best approach for management next? Is it A, start carvedilol, B, start lisinopril, C, balloon valvotomy, D, immediate cesarean section, or E, start digoxin? So as mentioned, this patient has severe mitral stenosis, and she's symptomatic at rest. She has class 4 heart failure symptoms with dyspnea at rest, orthopnea, and fatigue. She's given immediate support with oxygen and diuretics. But the next appropriate step, because she's symptomatic at rest, has severe stenosis, is to consider a balloon valvotomy to fix the structural problem. Carvedilol is not unreasonable, but she has class 4 heart failure, and so you shouldn't try to drive down the heart rate, which may in fact be compensatory. Lisinopril is an ACE inhibitor. ACE inhibitors are teratogenic in pregnancy. An immediate cesarean is not a great option. She's only at 25 weeks gestation. So if you have a way to preserve maternal health and bring the pregnancy to full gestation, that's preferable. And this is a representative picture of what rheumatic mitral stenosis might look like. This is from the atrial level. There's a fish mouth appearance of the mitral valve. The orifice is greatly diminished. There's this thickened leaflets of the mitral valve. Typically, patients have left-sided heart failure symptoms, can even have hemoptysis, can lead to right heart failure because of elevated pulmonary pressures. Often happens a decade or more after an episode of rheumatic fever. Echocardiography is useful to see if the valve leaflets are not calcified and seemingly pliable for a balloon valvotomy. Otherwise, surgery is sometimes needed. Mitral stenosis in pregnancy can be a big problem, particularly in the second trimester when there is plasma volume expansion and increased heart rate at baseline. We tend to treat the valve before delivery when there are class 3 or 4 symptoms. We also use beta blockers and diuretics with milder forms of mitral stenosis. But be aware that if a patient's on a beta blocker at the time of delivery, there can be bradycardia and even hypoglycemia in the newborn. And as ever, avoid ACE inhibitors in pregnancy or in patients who might become pregnant. Next question. A 48-year-old man with a history of hypertension presents to the emergency room with acute chest pain radiating to the back, accompanied by a hypotension and a new large left pleural effusion on chest x-ray. Systolic blood pressures differ in both arms by 22 millimeters of mercury, with a higher blood pressure in the right arm. Appropriate management steps include A, treat with sodium nitroprusside alone, B, start a loop diuretic alone, C, refer for urgent thoracentesis, D, refer for urgent surgical repair for a proximal aortic dissection, or E, narcotics for pain relief alone. So this is a fairly classic presentation of somebody who has an aortic dissection. So history of hypertension, and there's acute tearing chest pain radiating to the back with hypotension, a big effusion, and this differential in blood pressure. And that's highly indicative of a type A dissection extending past the aortic arch, possibly affecting the left subclavian artery. This is the typical distinction between proximal dissections, referred to as Stanford type A, and more distal descending aortic dissections of Stanford B. Typically, proximal dissections are surgical emergencies of the ascending aorta. Descending aortic dissections can sometimes, but not always, be managed medically and are typically seen in older patients. The acute management of aortic dissection, which is a true medical emergency, means stabilization and pain relief. Pain relief itself not only is valuable for the patient's experience, but reduces the catechol surges, which can increase the strain and tear the aorta even further. We often treat with a combination of sodium nitroprusside and beta blockers to reduce blood pressure and wall stress of the aorta. Immediate surgery is required for life-threatening complications, in this case, pleural effusion, suggestion of rupture into the chest. Urgent confirmation is required with echo, CAT scan, or whatever modality is locally available. And surgical consultation upstream is essential. As I mentioned, distal dissections are often seen in older patients than those with previously documented atherosclerotic vascular disease. Next question. A 50-year-old white male, included for purposes of a risk score, who has hypertension on lisinopril presents for a new visit. Does not take an aspirin or a statin. Does not have an exercise routine and is a non-smoker. No history of diabetes. His father had an MI at age 50. He's got a heart rate of 75, blood pressure 128/70 on treatment, BMI of 27. Total cholesterol is 220, LDL 160, and his ASCVD 10-year risk estimate is about 9%. In addition to lifestyle changes, what therapy would you recommend? A, lovastatin 2.5 daily. B, no additional therapies. Lifestyle changes are sufficient. C, fish oil 1,000 twice a day. D, ezetimibe 10 milligrams daily. And E, simvastatin 20 milligrams daily. So this is really a primary prevention case of somebody who has a sedentary lifestyle and multiple coronary risk factors, including hypertension and here dyslipidemia with an LDL of 160, with an intermediate 10-year risk of about 9%. And so I think the best therapy to recommend would be a statin, in this case simvastatin, 20 milligrams a day. Let's go through the more recent primary prevention guidelines for the management of cholesterol. A necessary first step in the guidelines, unless you're diabetic or have an extremely elevated LDL, is to then estimate the 10-year risk of atherosclerotic cardiovascular disease. So our patient here is between the age of 40 and 75, and their LDL is between 70 and 190. They've been identified as intermediate risk by having a 9% risk. And it's recommended at that point, in addition to the risk estimator, to If a risk enhancer, like family history, in this case his father having a heart attack, is warranted, to consider initiating a moderate intensity statin to reduce the LDL by 30 to 49%. And simvastatin at 20 milligrams is a moderate intensity statin. Lovastatin at 2.5, which is a fraction of the smallest dose pill, is a statin, but it's at a much, much lower potency dose. And because of this higher risk and the family history, I think it's reasonable to initiate a statin here to reduce cardiovascular events. This is the atherosclerotic cardiovascular risk disease estimator with the website here. Very user-friendly, good for shared decision-making with patients. Often we can look at therapeutic impact in real time with patients at our clinic encounters to show what the impact of treating cholesterol or blood pressure might actually be. As for statin therapy, statins are often divided into high, moderate, or low intensity. The ones to remember are high intensity statins, are really high dose atorvastatin and rosuvastatin. Moderate intensity statins, including simvastatin 20, which was the answer here, are often started for most everybody else. Next question. A 69-year-old man returns for follow-up after an anterior MI 2 months ago, complicated by heart failure. On maximum medical therapy, though, he has no symptoms. Follow-up echo shows an improved ejection fraction from 20% at the time of the MI all the way up to 33% today. What would you do next? A, consider an ICD only if he becomes symptomatic. B, refer for cardiac resynchronization pacemaker. C, repeat echocardiogram in another month to see if an EF improves prior to implanting an ICD. D, consider a cardiac MRI. Or E, educate the patient about the contraindication of ICD due to his age. What would you do next? Well, I think a reasonable thing to do next is to consider an ICD only if he becomes symptomatic. We'll go through the ICD recommendations, but I'll go through and tell you that the other answers don't make a lot of sense. Resynchronization is great if you have a wide left bundle. There's no mention of that here. Repeating echo is valuable, but in this case, because the patient is asymptomatic and has an EF more than 30, there's no indication for ICD. An MRI doesn't help you in the ICD sudden death decision-making here, and ICDs are still absolutely implanted when you're 69 years old. So who gets primary prevention implantable cardioverter defibrillators? Well, these are generally patients who have an EF 35% or less, who are at least 40 days out from a heart attack, and are symptomatic in class 2 or class 3. This patient has no symptoms. Or in patients with an MI more than 40 days out, whose EF is less than or equal to 30%, even if you're just class 1. So because this patient's ejection fraction is more than 30%, and they're asymptomatic, they wouldn't meet the level of class 1 recommendations for an ICD. And then, of course, survivors of sudden death who get a secondary prevention device can get one of them as well. The boards typically will only test you on the class 1 recommendations for drug and device therapy, or the class 3s. Whatever you do, don't do that recommendations. Next question. A 63-year-old man has recurrent non-sustained ventricular tachycardia up to 9 beats in the setting of an acute MI. He has mild signs of heart failure, and successful stent is placed in the left anterior descending artery. His ejection fraction is 25%. Which statement is true? ACE inhibitors do not improve outcomes in this population. Implantable defibrillators should be performed prior to discharge. Lidocaine should be started at this time. Beta blockers may improve survival and should be started once congestion is resolved prior to discharge. And eplerenone is not associated with improved survival. Which statement is true? Well, the true statement is that beta blockers absolutely improve survival and should be started after the patient's decongested and before discharge. We also know that ACE inhibitors improve outcomes, so that's incorrect. ICD should be deferred for primary prevention until more than 40 days after an MI. Lidocaine doesn't favor outcomes. And in fact, eplerenone is also associated with improved survival based on the EPHASIS study. The beta blocker data after MI are robust. These are data from the Capricorn study of outcomes after MI in patients with EF less than 40%, showing improved survival. So classic post-MI management, everybody should get an ACE inhibitor. If they can and they have heart failure symptoms or diabetes with a low EF, they should be started on eplerenone. ICD should be deferred for 40 days. There can be an excess risk for a type 1 antiarrhythmic agent. You treat the MI and the myocardium with the beta blocker, not necessarily the non-cysteine VT, which might abate with beta blocker. Next question. A 35-year-old woman presents to the emergency room following a motor vehicle accident in which she was wearing a seatbelt. She noted mild dizziness while driving and awakened to find herself on the side of the road. Past medical history is notable for cutaneous sarcoidosis. She takes hydroxychloroquine and prednisone. A physical exam is remarkable for mild facial lacerations. What is the most likely cause of this event? Is it A, hysterical fainting, B, epilepsy, C, hypoxemia, D, neurocardiogenic syncope, or E, ventricular tachycardia? And so from the stem, you see that the patient had mild dizziness and then awoke on the side of the road. So not much of a prodrome or aura. She also has a history of systemic sarcoidosis, which we know can have cardiac involvement. So I think the most likely cause of this event was ventricular tachycardia. Going through the potential causes of history, of syncope rather, the history is really important. So it pays to take time to do a very thorough history. Cardiac syncope often arises rapidly, without an aura, and has a clear sensorium thereafter. It can be seen with a history of coronary disease or low EF, and often there's trauma associated with the syncope, in this case a motor vehicle crash. Bradyarrhythmias, so slow heartbeats, seen when there's a history of conduction disease or prior heart transplant, whereas neurologic syncope often precedes with an aura, clouded sensorium. There can be incontinence or seizure-like activity. And hysterical fainting, on the other hand, is not accompanied by a change in vital signs. There can be hyperventilation, paresthesias, and frank signs of anxiety, none of which is mentioned in the stem. Neurocardiogenic syncope, which is the most common cause of syncope, which this is not, often is seen in emotional distress where there's pain, fatigue, fear, often in a setting of dehydration that leads to an elevated catechol state, sympathetic activation of the heart, which stimulates mechanoreceptors and leads to reflex vasodilatation and bradycardia. In contrast, this patient had seemingly unheralded syncope with trauma and a history of a systemic disease that can affect the heart. And so I think ventricular tachycardia is likely the most reasonable etiology. Question number 13. A 38-year-old attorney has experienced palpitations over the last 2 years. There are no associated symptoms such as dizziness, syncope, or sweating. She's otherwise healthy and her exam is normal, except she's got a heart rate of 108, which increases to 128 when she stands and presents to an audience. Electrocardiogram reveals sinus tachycardia and is otherwise normal. Stress reduction and caffeine reduction don't change her symptoms. What is the best treatment for the palpitations? Is it dofetilide, nadolol, radiofrequency ablation, amiodarone, or nifedipine? So this patient has situational sinus tachycardia. That's the only arrhythmia that's been identified here. And so the best thing to reduce the negative biofeedback of sinus tachycardia and nervousness, which can in turn lead to worsening tachycardia, is a beta blocker, nadolol. A class 3 antiarrhythmic like dofetilide isn't indicated, and since this is sinus tachycardia, ablation would mean ablating the sinus node. Amiodarone is not very useful in these circumstances, and nifedipine, which is a dihydropyridine calcium channel blocker, is a vasodilator, and if anything may lead to reflex tachycardia. So nadolol is a good choice. The other interventions are widely used: amiodarone for both atrial and ventricular arrhythmias, dofetilide, again for atrial arrhythmias. Beta blockers are wonderful for sinus tachycardia, palpitations, and obviously a various number of cardiovascular conditions, as you've already seen in these questions. And ablation is great for atrial arrhythmias as well as atrial tachycardia. But again, this patient seemed to have sinus tachycardia. So let's try nadolol. Question 14. A 72-year-old man with a history of severe mitral regurgitation from anterior mitral leaflet prolapse has an EF of 50% and a mildly enlarged left heart at 59 millimeters, presenting for a second opinion. He reports that dyspnea occurs when walking up one flight of stairs, and he's otherwise very healthy. What is the best option for management? Is it A, refer for mitral valve surgery, B, refer for percutaneous transcatheter MitraClip, C, follow serial echoes and plan surgery when the ejection fraction goes below 35, D, start an ACE inhibitor to attenuate the progression of LV dilatation, or E, refer for cardiac resynchronization to reduce mitral regurgitation. I think the best option for management here is refer for mitral surgery. This patient has severe symptomatic mitral regurgitation and already has signs of ventricular remodeling. Importantly, the regurgitation is coming from a primary mitral leaflet problem, not a heart muscle disorder or heart failure. There's a leaflet problem, and there really isn't a pill for that. These are the recommendations for mitral valve surgery for severe primary mitral regurgitation from the latest valvular heart disease guidelines. So if you have primary mitral regurgitation that is severe, if you're symptomatic, so-called stage D valvular disease, and your ejection fraction is more than 30%, then mitral valve surgery is a class 1 recommendation. This patient is probably low risk for surgery based on no other health problems or issues, and so surgery, preferably with a repair rather than replacement, is likely to give the best long-term outcome. It's very helpful to pull up such guidelines and walk through them with your patients. One teaching point here is that you want to avoid waiting until the ventricle is terribly weak, because that's where the risk really goes up. In addition, unless there's concomitant hypertension, elevated blood pressure, an ACE inhibitor is probably not going to help you. Similarly, resynchronization therapy, great for wide left bundle branch blocks. There's no mention of that here in the questions. Next question. Please review the following ECG. Each of the following statements about this ECG finding is true, except exercise testing should include imaging. This can represent end organ damage from systemic hypertension. Repolarization will normalize with exercise. This condition can be seen with both eccentric and concentric ventricular remodeling. And E, this ECG is diagnostic for left ventricular hypertrophy. So indeed, this is a classic ECG for left ventricular hypertrophy with repolarization abnormalities. There are deep S waves in the precordium, in this case about 25 millimeters. Similarly, very tall R waves in the apical leads. Collectively, this is consistent with LVH. There are diffuse ST segment depressions and T wave inversions as well. So any stress testing has to have imaging because it's hard to interpret the ST segments. When the heart is hypertrophy from high blood pressure, that can represent end organ damage. And these repolarization abnormalities will persist with exercise. And so that is false. They won't normalize with exercise. They'll persist. And it can be seen in any cause of increased left ventricular mass. And indeed, the ECG is diagnostic of electrocardiographic hypertrophy. Next question. A 56-year-old presents for a new visit for management of his chronic heart failure with ejection fraction 30%. He has New York Heart Association Class 3 functional limitation. Current medications include lisinopril, carvedilol, and furosemide. Which of the following statements regarding therapy to improve survival is correct? A, hydralazine plus isosorbide dinitrate improves survival in self-described African American heart failure patients already on ACE inhibitors and beta blockers. B, aldosterone receptor antagonists reduce all-cause mortality with class 3 and 4 heart failure, with MI patients with heart failure and older patients with milder forms of heart failure. C, resynchronization improves survival in patients with mild heart failure provided there's a left bundle branch block with a wide QRS. D, angiotensin II receptor blockers can improve cardiovascular survival in patients intolerant to ACE inhibitors due to cough. Or E, all of the above are correct. Well, in fact, it's E. All of the above are correct. The AHEF study showed a 43% decrease in death with isosorbide and hydralazine in combination in patients who are self-described African Americans already on ACE inhibitors and beta blockers. The emphasis trial in mild heart failure showed that there was a reduction that was statistically significant of cardiovascular death, as well as the combined endpoint of death and hospitalization in patients with mild heart failure, class 1 and 2, following a discharge from a heart failure hospitalization. And the CHARM alternative study showed a reduction in cardiovascular death or heart failure hospitalization in patients who were placed on an angiotensin receptor blocker, candesartan, who were intolerant to ACE inhibitors. So there's a whole menu of options to improve outcomes in patients with low EF heart failure. Question 17. A 52-year-old male presents to clinic for perioperative evaluation prior to elective cholecystectomy. He works full-time in construction, pretty strenuous job, and exercises by walking 40 minutes several times per week. Past medical history is notable for high blood pressure, high cholesterol, and a remote heart attack 3 years ago. What's the best management? A, coronary angiography prior to this elective surgery. B, perform the cholecystectomy, but only if it's an emergency. C, stress test with a sestamibi scan or echocardiogram. D, proceed with surgery and ensure beta blocker use. Or E, stress test without imaging. Well, I think the most appropriate answer in this case is proceed with this surgery and ensure beta blocker use. So this is elective surgery. It's not vascular surgery or neurosurgery. And this patient can do a lot. He works construction. He exercises 40 minutes several times a week. So there's a robust exercise history and no report of effort intolerance given, despite his prior coronary history. And so we know from decades of research that we can calculate risk for non-cardiac surgery based on several things: age, recent heart attack, physical exam, ECG, and the like. The main take-home point here is that for low-risk surgeries like an elective gallbladder removal, is that if you're able to do more than 4 metabolic equivalents, which is about doing heavy housework, lifting, moving furniture, scrubbing the floors, you're able to do that without any limitation. You're at very low perioperative risk for coronary artery disease events. In contrast, this patient works construction and can walk 40 minutes at a time, so it sounds like they can do more than 4 mets. More recent guidelines for predictors of those things requiring intensive management around the time of surgery. The big things to remember are acute coronary syndromes, so take a history. Is there unstable angina or recent MI within the last few months? Is there decompensated heart failure, symptoms at rest? Are there significant arrhythmias, either heart block, poorly rate-controlled atrial fibrillation, or VT? And is there severe stenotic valvular disease, particularly aortic stenosis or mitral stenosis? You can pretty much get all of that with a good history, physical exam, and an ECG, and therefore clear somebody. But we know if they do have a history of coronary disease, they should have a beta blocker to shield the heart from the stress of surgery, no matter what. Next question. A 53-year-old woman who's not seen a doctor in 10 years presents to clinic for a routine visit given vague chest pain and fatigue. She's on no medicines, denies allergies, or any past medical history. She noticed her blood pressure was 170 over 100 at a drugstore 4 weeks ago, which is what got her in to see you. She's tried decreasing her salt intake on her own, but her exam demonstrates blood pressure 166 over 106, heart rate of 76. You do an eye exam and notice AV nicking, and heart shows a loud S2. Jugular venous pressure is normal, as are her labs and ECG, but she has uncontrolled diabetes on a urinary dipstick that also shows proteinuria. You decide to get an echo to be thorough, and her EF is only 40%. While arranging for a cardiac catheterization, what is your best option? Should you start some enalapril now? Should you suggest further lifestyle change and recheck the blood pressure in a month? Should you start hydrochlorothiazide? Should you refer for a defibrillator? Or should you start diltiazem? Well, my concern with this patient is that she's got poorly controlled blood pressure. In addition, she has diabetes, proteinuria, and a reduced ejection fraction. So I think the next best step is to start some sort of blood pressure lowering medication. But given the diabetes, proteinuria, and low EF, it's good to start a blood pressure medicine that might also help those. That's why I think starting an ACE inhibitor, enalapril, is the next best option. Hypertension therapy, we've gone through the guidelines for when we should start treatment. And here this patient has symptomatic stage 2 hypertension, symptomatic because of the proteinuria. First-line therapy is often a diuretic, but we can tailor our choices for specific populations. Again, this patient has diabetes, low EF, and proteinuria, so maybe an ACE inhibitor is a good first-line choice. We recognize that 2 or even 3 medicines are often required, and that screening for secondary causes of hypertension are particularly important. In patients who might be obese, where you're thinking of sleep apnea, have a renal bruit, if you're thinking of fibromuscular dysplasia or renal artery stenosis, and the like. Question 19. A 69-year-old woman with a history of mitral valve prolapse with mild to moderate regurgitation presents to your clinic. She's asymptomatic and has a past medical history also of controlled hypertension and dyslipidemia, but no history of endocarditis. She's scheduled for a dental extraction next week. What is the best recommendation for endocarditis prophylaxis? Is it amoxicillin 2 grams orally an hour before the procedure, clindamycin 600 milligrams an hour before, ampicillin 2 grams intravenously 30 minutes before, D, all are acceptable, or E, none of the above? What's the best recommendation for this patient with mitral valve prolapse and mild to moderate MR for endocarditis prophylaxis? Well, it's true that the first 3 are perfectly appropriate endocarditis prophylaxis regimens, but this patient doesn't need endocarditis prophylaxis. And that's because the latest guidelines suggest that in patients who have mitral valve prolapse with only mild to moderate regurgitation, no prophylaxis is recommended. And that's balancing the risk of diabetic resistance within the community and the individual risk of endocarditis with a dental cleaning, which is extremely low for mitral valve prophylaxis. So we prophylax when there are prosthetic valves, prior endocarditis, unrepaired congenital heart disease, cardiac transplantation with valvular disease. We don't prophylax routinely for hypertrophic cardiomyopathy or mitral valve prolapse merely with thickened veins. And now question 20, our final question. A 45-year-old man presents to the emergency room with dyspnea. Blood pressure was 228 over 110. The remainder of his physical exam was notable for faint pulmonary crackles. Which of the following findings are characteristics of a hypertensive crisis? A, retinal hemorrhages. B, microangiopathic hemolytic anemia. C, azotemia and proteinuria. D, pulmonary edema and jugular venous distension. Or E, all are characteristics of hypertensive crisis. That's right, all of these things are characteristics. So retinal hemorrhages, hemolytic anemia, azotemia, proteinuria, and pulmonary edema. This patient may have early pulmonary edema and certainly has severely elevated blood pressure. Additional things, you can have renal injury, you can have frank heart failure because of the load imposed on the heart, as well as nausea and vomiting. And perhaps the most feared complication is hypertensive encephalopathy. This is where there's confusion, irritability, headaches, seizures, and even coma due to a sudden rise in blood pressure, where your brain can't auto-regulate quite fast enough. And hypertensive encephalopathy need not have blood pressures of 250 over 200, but it's the sudden increase in blood pressure that can lead to this syndrome. And a high index of suspicion is needed to get on top of this and control the blood pressure judiciously. Thank you very much for your attention. Good luck in preparation for your studies and upcoming boards.